It's 4:02, so welcome everyone. This is our latest Endocrine Surgery University webinar, and it's titled Addressing Inequities in Endocrine Surgery Care and Practice. And we're very lucky to have two outstanding speakers tonight. So first, Andrea Gillis, who many of you may have met either on the interview trail or just in hanging around endocrine surgery or academic surgery type events. She's on faculty at University of Alabama, Birmingham. Just a year or so ago, she was in, 2 years ago, 1 year ago, when'd you finish?
Last year.
Yeah, I know, craziness, right? So I mean, just a very short time ago, she
like
was
6 months in.
Yeah, she was sitting in your position, doing Endocrine Surgery University and getting set, and already in short time on faculty has made a lot of impacts, and we're very excited to hear from her. And then the other speaker tonight is Dr. Tony Bogany, who is a surgeon down at Naval Hospital down in San Diego. Proud to have been part of his endocrine surgery training at UCSF in 2014. And he's going to talk to us as representative of the AAES DEI committee. So we're going to start with Dr. Gillis, and then we'll turn it over to Tony, and then we can open it up for questions after that and discussion. I'd like to leave a little time for that. And then, like I said, also at the very end, we'll talk a little bit about what to expect for in-person ESU next month. So Dr. Gillis, I think we're seeing your presenter mode, so if you want to flip the thing. There you go. Hold on. No, you can stay in the chair. You just have to.
We've just practiced this.
Oh, that's all good. Let's see.
Oh, I think it's because I switched my screen.
Yeah, just try it again. We'll get you there.
There we go.
Beautiful.
How about that?
All right, take it away, Andrea.
All right. Well, thank you, Wynn, for inviting me, and thanks all the fellows for your attention. And I'm really excited for the discussion we're going to have today. So we're going to talk about addressing inequities in endocrine surgical care and practice. So I have no financial disclosures. I will disclose I'm not a health services research expert or an expert in disparities, but this is a field that I've enjoyed working in. So I just wanted to share, some of my thoughts and some of the great work that's been done already before me. So just an outline. So my task is in 20 minutes or so to share with you all of the inequities in endocrine surgery. So we're going to start with some definitions, and then each of our three favorite organ systems. So what are inequities? And I think, we chose the title of this talk with intention, specifically to focus on inequities in endocrine surgery. So there are many terms thrown around, and a lot of research gets done without, proper frameworks or definitions. So just so we're all on the same page as we get started, I wanted to throw or shine attention to, there are differences between all these things. So disparities is just a term that means difference. It doesn't necessarily have to have a negative connotation. But disparities can be like a giant umbrella term, and it can encompass a complex interplay of healthcare factors, as well as patient factors and society factors. So things like patient demographics, access to care, and then social factors like education. And so healthcare disparities are specifically focused on, healthcare, access to care, outcomes that patients may face. And so when we think about healthcare disparities, the NIH actually provides a pretty nice framework that a lot of researchers in this space rely on, these 5 different domains of social determinants of health, which then influence disparities. And so these domains affect the way that people are born, how they live, where they work, how they age, and basically their entire lifespan. So each of these domains can impact the person at various time points. And in addition to the individual conditions, they also encompass the wider set of forces that the entire society lives in, and that shapes the conditions that people then live in and access their healthcare through. So these 5 domains are education, access, and quality, economic stability, which notably is different than income, but kind of their long-term longitudinal income, or wealth is another term that's used. Social and community context, so how they interact with the people around them, including their providers and their neighborhood. And the neighborhood and built environment is more of the infrastructure. So do they have access to green space? Do they have access to hospitals? And then healthcare access and quality is what are the types of hospitals they have access to, and what's the quality of care that is provided to them or provided to the entire system. And then so when we move to talking about equity, health equity, and inequity, that's kind of a totally different term. So equity and inequity refer to the systemic and often unavoidable or unfair differences that patients live in or access care through. So everyone has social determinants of health. It's not necessarily a good thing or a bad thing, but when they become socially vulnerable, then they fall into the bucket of facing inequities. And so the kind of overarching existential question about, why do we even care about this is, all doctors, I believe, are good and want to be good and treat their patients fairly and have great outcomes. But the thing that we notice is even if we provide equal care or care to exactly the same to every person, they can have inequitable outcomes. And so the goal, I think, is how can we help everyone do better, if not the same? And so in order to answer that question, we have to study these things, like what exactly are contributing to inequities. And so if you want to study social determinants, you have to define your population. And so there's a lot of hairiness when defining things as simple as race. Is it self-identified race? Is it biologic race? Is it ancestry? Is it ethnicity? The two are not necessarily the same thing, but they often get lumped together. Gender, LGBTQIA identifying. These are things that we don't often ask patients, but we just assume and assign them. And then so when you're looking at outcomes, you have to really think, is this how the person identifies or how the system identifies them? And then that can open up a whole different can of worms in terms of expected outcomes. And then socially vulnerable links to social determinants of health. So which of those 5 domains are you exactly identifying them as being a part of? And so the NIH has these predefined categories, but if you've ever looked at some of the NIH toolboxes, they have like 20 different definitions of race. Like Black is not just Black, there's African American, African Caribbean. So the more you divide people up, the harder it is to draw conclusions, even though you are being more accurate. And then so we think about where do we get this data? Lots of people love to query SEER and CDB, these gigantic databases, because basically anything you search for will give you a significant p-value. But then when you take a step back, like how reliable are these databases? Oftentimes they're abstracted by someone who is not a physician. And then the definitions that they're given are not necessarily clinically relevant. So the common one that we think about is nerve injury. So if someone has any kind of voice change or hoarseness, they automatically get the checkbox of nerve injury, even if they had a negative laryngoscopy or some other exam. But then when we think about disparities and we look that up, we can get totally different results from these databases. And the other thing is how accurate are these in terms of defining populations? So there have been several studies that look at both EMRs as well as giant databases and find that the way that patients are identified or defined can be hugely erroneous. So about 20% of minorities in this study were misclassified, and ethnicity is much easier to misclassify than race, but both of them can end up being erroneous. And so just to draw another big curveball at you, there's lots of different ways to analyze both the domains of influence, so exactly which domain of social determinants are we looking at, and also the levels of influence. So all of those 5 domains have different levels, both from the individual level, interpersonal, community, and society. So each of these little boxes, and this is from the National Institute of Minority Health and Health Disparities, each of these have data or have ways to measure that are supported by data. So like I said, lots of people like to get into the disparities workspace and they, pick something randomly when very smart people have gone through the work of validating some of these scales and measurements. And as you can see, there's numerous of them. And each of these domains affects, what we're going to talk about at different levels, from incidence to diagnosis, treatment, outcomes, and follow-up. So as we go through the different organ systems, I wanted to draw attention to different levels at which disparities pop up. So from incidence all the way to outcomes and follow-ups. So now, and start with thyroid. So instead of just giving you a laundry list of every disparities paper that's come out, I decided to focus on some of the more salient ones and sort of dive deep into just a handful of, some of these papers and works that can guide how we think about caring for our patients with these different diseases. So in terms of benign thyroid disease, not much has been done in terms of diagnosis and incidence, but there was a paper, like a big sort of Census Bureau-like study of patients in Canada, just asking every single person if they've had anyone evaluate them for any kind of thyroid disorder, whether they had a diagnosis or not. And fewer minorities and immigrants in Canada reported that they had ever even been diagnosed or had blood work looking for a thyroid disorder. And then looking at referrals, so who gets referred for any type of intervention. And so this study from 2016 looked at all patients who had thyroidectomies, and Black patients tended to be referred when they had much more severe symptoms. So when they were older, more goiters versus just an incidental nodule, more severe symptoms, compression, and dysphagia. And then once they get one of these diagnoses, the evaluation can be different also by race. So this study in 2018 looked at everyone who had a biopsy for a thyroid nodule. And of all patients who got biopsies, white patients were more likely to be referred for a biopsy based off an incidental finding versus something symptomatic. And so when they looked at all biopsies, if it was a biopsy in a white patient, it was more likely to find a cancer. But then we think about, well, who even got referred to get a biopsy? Much more white patients got referred to get a biopsy. So of course, they're more likely to find a cancer. So oftentimes we hear that thyroid cancer is less common in racial minorities, but that may just be referral bias. And then looking at, a different type of benign thyroid disease, Graves' disease. So very common. And we've actually studied in our institutional database that although patients may carry this diagnosis, very few of them ever actually get diagnosed, even if they had biochemical disease, or get referred to anyone, surgeon or for RAI. And so in this study of 3,000 patients, only 33% of them actually carry the diagnosis of Graves' disease or even hyperthyroidism, despite having undetectable TSH. So some of that is, lack of follow-up. Some of it is sort of just internalized bias. People are, worried about lots of other things when they see a patient. They may not necessarily think about their Graves' disease. And so we looked at who was more likely to carry the diagnosis, even if they had the biochemical disease. So patients with eye disease. So, obviously the provider sees the eye disease, they give them the diagnosis, make sure they get the proper evaluation. African Americans, younger patients, patients with private insurance, and no comorbidity. So that kind of goes along with, our own, what are we distracted by when we see a patient? If they have a bunch of other things to be evaluated, the Graves' disease kind of falls to the wayside. And so we know that if people carry Graves' disease without any kind of intervention, there's all kinds of complications that they can suffer from. So, we kind of have a call to arms that, we need everyone with hyperthyroidism to carry this diagnosis and get further evaluation. And so we think about, what is the incidence of Graves' disease? There hasn't been a ton of research into this, but a really great study by McLeod in 2014 looked at a military database, which is always a really nice database to look at because everyone has insurance and everyone has access to either VA care or when they're on active duty, a physician from the military. And so they found that young, healthy population, Graves' disease was more common in Black males and Black females than their white counterparts. And so then again, thinking about who gets referred for surgery, this paper out of Wisconsin looked at a 5-year time span, every patient who got some kind of definitive management for Graves. And as they did the study, surgery became much more common. And they found that Black patients were more likely to be referred for surgery, those with ophthalmopathy, more likely, goiters more likely, and those in the lowest quartile income were more likely to be referred for surgery. When they did a multivariate logistic regression, race fell out and income fell out, was no longer significant. That may just be because of the makeup of Wisconsin. They didn't have enough people in some of the minority subsets. But younger age, female, and ophthalmopathy, and longer time that they were doing the study were more likely to get surgery. These are just like things to keep in mind that patients may be getting inequitable care, even if they, these people, even if they had ophthalmopathy, some of them still got RAI. And so we know that that's not really indicated. So just thinking about, what was special or different about these patients to end up getting that type of treatment. And then so we look at outcomes, again, along that disease spectrum. There honestly is not a ton of research on Graves' outcomes, specifically looking at differences in race or ethnicity. So I think this could be a pretty good area to study. But when we looked at outcomes, there was a really nice study out of Duke where they applied this MD Anderson symptom inventory to patients with Graves, looking at specific patient-reported outcomes. And so they had 50 patients and they looked at before surgery, about 30 days after surgery, and then greater than 30 days, so long-term outcomes. And for every symptom scale that they looked at, there was an improvement in quality of life compared to before surgery. And believe it or not, there have not been a ton of these studies done in the US that also looks at an ethnically diverse population. And this study from North Carolina had about 30% Black patients. Unfortunately, when they looked specifically at race and ethnicity, they saw that non-Hispanic Black race was associated with worse symptom scores. And so that's before, after, and long-term after surgery. There was no difference for Hispanic ethnicity. So this may be related to more severe disease at presentation. Like, it's hard to get patients feeling completely better if they've been living for 5-10 years with a giant goiter and severe symptoms. And then looking at weight gain or weight loss after surgery, again, not a ton of studies looking at this specifically by race or any other social economic factor. There was one study in the pediatric population that showed everyone gained weight initially after thyroidectomy for Graves, but most of the people then later lost that weight. So they followed these kids for 2 years after the thyroidectomy, and Hispanic ethnicity was one of the predictors of the patients continuing to have increased BMI even after their Graves was cured. And so now moving on to thyroid cancer, ton has been written about this, different from Graves, and especially in these big databases. So one thing we're often taught is that thyroid cancer is more common in women. So there may be a gender disparity there. This study actually looked at autopsy reports in addition to clinical diagnoses. So they combined, both the databases and autopsy reports. And they found that small cancers are diagnosed more often in women, but when they included the autopsy reports, men had just as many small cancers as women did. So the odds for a small cancer, meaning less than 2 centimeters, how they defined it, was not different by race. And then when they looked at more advanced cancers, there was no difference by race either. So what they concluded was women may be more likely to be diagnosed with thyroid cancer because we're kind of expecting it, whereas men may harbor these small thyroid cancers, but they're not getting ultrasounds, they're not getting TSHs or TFTs checked. So it kind of just gets missed, and then they just end up dying with thyroid cancer and no one ever knew about it. And then when we look at incidence by race or ethnicity, so this pretty interesting study out of Mount Sinai in 2018 looked at how accurate are these systems that we've sort of made to stratify biopsies and ultrasounds, because a lot of them were developed in pretty homogeneous populations. And so in New York, it's a very diverse patient population. They looked at all of their thyroid FNAs and found that the Bethesda system actually was not very accurate in racial and ethnic minorities. So the positive predictive value was lowest in African-American patients, followed by Hispanics, and then whites. And this was statistically different for positive predictive value, but not so for sensitivity and specificity. And this probably has to do with the incidence of thyroid cancer in the population. Because these systems were not developed in a diverse population, the predictive indices are not necessarily valid in certain other minority populations. And then when we look at, again, big SEER database, Harari did a big California database looking at incidence of thyroid cancer by race. And they found that Black patients are more likely to have larger tumors, and they define this as greater than 1 centimeter, as well as larger tumors greater than 4 centimeters. So I think that greater than 1 centimeter is less of an access difference or inequity. because, they're still finding these smaller cancers, but they were more common in Black patients. So that makes me think there's maybe a biologic difference. And again, to support that, from the same database, they found that Black patients were almost twice as likely to have follicular carcinomas compared to their white controls. And Liu Young added the Chicago database in addition to SEER in order to get a more diverse patient population, found that Hispanic patients were more likely to present at younger ages and more advanced disease with lymph node metastases. This Nash paper from 2018 kind of delved more into that other category that we see a lot in SEER, and what specific race were these people in the other category. And they found that Native Alaskans also presented with more advanced disease. And there was a couple of studies like that looking at specific Asian subtypes. So Filipino patients had more advanced disease compared to other Asian ethnicities. And then so more to, is this a biologic difference? One of the few genes that we know about that sort of drives more advanced thyroid cancer, this BRAF V600E, did not significantly contribute to difference in survival by race. So maybe there's something else we don't know about, but it wasn't just BRAF alone. And then looking at things other than race ethnicity, so insurance status. This is an NYU study in 2012. They have a pretty unique setup with Bellevue and the Tisch Hospital being basically across the street from each other. So they compared their patients, and they basically have the same surgeons, same access to care. Only 2% of their patients were insured, so they probably were not seeing doctors as often as the private hospital counterparts. But the public hospital patients had more advanced stages, extrathyroidal extension, and more advanced disease, so distally metastatic disease as well. So there's also a difference by socioeconomic status. And so then we look at appropriateness of treatment. So how many patients were getting appropriate lobectomy or appropriate total thyroidectomies as the guidelines recommend. So in the NCDB, Black patients had lower odds of appropriate operations by about 30% less likely than their white counterparts. And then also for adjuvant therapy, so RAI was more likely given Hispanics, RAI under treatment was more likely in Hispanics and Blacks and Asians than whites. So they were getting unnecessary additional RAI. But overall, the outcomes are still worse. So in this study, looking more at intersectionality, so if you're a minority both racially and minority within the disease status, which I think is a really interesting way of looking at it. So Black males had the highest mortality compared to non-white females, white males, and white females for thyroid cancer. And this is after they controlled for age, cancer type, stage, surgical procedure, and RAI. So that makes you think it's an access problem or a disease burden problem, not necessarily a biology problem. And then this is that foreign-born Filipino study that these patients also had higher mortality. And then looking at more patient-reported outcomes. So also very important in addition to the textbook outcomes that we're familiar with, but thinking about post-cancer related worry. So how much of a burden is this diagnosis on patients? So this study saw that Hispanic and Asian ethnicities are more likely to worry about their disease even after treatment. And then Debbie Chen, who works at UCLA, who does a lot in this space, especially for Hispanic patients and looking at acculturation and financial toxicity, she evaluated these patients, and especially low acculturated Hispanic women, had tons of financial hardship after being treated for thyroid cancer. So even if we have great textbook outcomes, if we're not supporting our patients equally or equitably for economic and emotional support, we're still having disparate outcomes. And so a little bit about parathyroid. This has been studied in a variety of populations, which I think lends itself to a divergence of the data on outcomes. So when we look at giant databases, NCDB or NSQIP, Medicare databases, find that African-American patients with parathyroid disease are sicker, more comorbidities, more CKD, but they tend to have less bone disease and less kidney stones, sort of the typical sequelae of hyperparathyroidism. And maybe for this reason, they tend to be delayed in being referred to surgery or even offered surgery. And so unfortunately, in this Medicare database, they can search for symptomatic and hyperparathyroidism. So these are all symptomatic patients. None of them really got referred for surgery, like 9% in the entire database. But then when they broke down that 9%, you were most likely to get referred for surgery if you were white, and then less so for Black, Hispanic, and Asian. And this is within 1 year of carrying this diagnosis. And so if they are referred to surgery in this national inpatient sample, they were more likely to be referred to a low volume surgeon. And this is less than 2 parathyroids per year. These are the surgeons that are most likely operating on males, Hispanics, African Americans, those with public insurance. And we know that they have more complications. So that's sort of why some data supports that minorities with hyperparathyroidism have more complications after surgery. But then when we take a more refined look at this and look at high volume surgeons, a lot of those differences disappear. So although in the study from Penn, the African-American patients had the same number of symptoms, they were less likely to get the appropriate preoperative evaluation. So like DEXA, didn't carry diagnoses of bone disease or kidney stones. They also had more comorbidities at baseline, but they had similar operative success. So same number of recurrence, and same percent of cure. So we looked at exactly what is the delay in parathyroid disease. So we know that these patients are less likely to be referred, but we wanted to see, how long did it take for patients to be referred, and was there a difference by race or ethnicity? So in our institutional database over this 4-year period, only 21% of patients with biochemical disease were referred for surgery. So similarly poor referral rate. But of these, you were least likely to be referred if, again, you were a Black man, then Black women, then white men and white women were about the same. And when they looked at how long it took for people to be referred, even if they did get referred, there was a huge delay. So 13 months for African-American men, 7 months for African-American women, almost twice their counterparts' length of time before being referred to a surgery. And they even adjusted for age, comorbidities. Maybe they were really, really sick, and that's why no one wanted to refer them. But even after adjusting for that, these differences remained. And so I looked at, if they were referred, do we still get the same outcomes? And so again, in our institutional database, Black patients, I looked at primary and tertiary hyperpara. There's almost nothing written about tertiary hyperparathyroidism and referral rates or outcomes. So I combined both of our subsets in our database and found again that Black patients were more likely to have elevated PTHs and calciums, but were younger in age. So that speaks less of an access problem and maybe more of a biology problem. I have no idea how to explain that. They had the same number of adenomas and multi-gland disease. Makes me think there may be some difference in either bone metabolism, calcium metabolism, or something different with biology. There's definitely a difference there, but in at least our hands, there wasn't an inequity there. And so just looking at all patients with neck surgery, lots of databases combine the two because they don't have enough parathyroids. In patients who had any type of neck surgery, this study looked at patient-reported neck symptoms or voice changes, and they both scoped them, so they had objective findings as well as subjective findings. And even if there were no objective findings, there were no difference by race or ethnicity, the Black patients still had more subjective voice changes at 6 months. So not sure what's causing that difference, but there definitely was a difference there in a well-designed observational prospective study. And then looking again at long-term outcomes by both race and socioeconomic status, Black patients and those in high health risk communities, and this is an inpatient study, so we have to kind of take that with a grain of salt. These people are already admitted to the hospital. If you were Black or Hispanic or came from a community that had high health risks, you were more likely to have a longer hospital stay, more likely to be admitted to an ICU, more costly care, and they equated that to being cared for by more low volume surgeons, and more likely to have postoperative complications. Interestingly though, when they adjusted for the volume of surgeon, these differences still remained. And then so my interpretations basically about neck surgery, because that's all I can really talk about, is that, kind of the key practices, why do we see a difference in high volume surgeons versus these national databases and outcomes of care is that, high volume surgeons, many reps, they can become more efficient. They have these standardized protocols that end up saving time and money for the patients. Many of us don't require that referring physicians get all of this workup and evaluation, which has been shown to delay time to referral and even the likelihood of referral. We like to see patients ourselves. We'll get our own ultrasounds, and that's a little bit different than people who are lower volume. I think at least here we allow self-referrals, which can be another barrier for patients, especially if they find that they're being treated differently. They don't think that they're going to get a referral. They may never follow up. And so allowing self-referrals can kind of reduce that barrier. And we've actually found there's no difference in the number of people that we refer for surgical procedures if they were referred by a primary care doctor or if they're a self-referral. Like patients, especially in social media age, tend to kind of know what's going on. And then again, standardizing pre and post-op protocols, having a good support staff and a good follow-up so that you can identify people who need to be rescued. I think a lot of lower volume or places that don't do this very often can't always identify that. And this may prevent some of those negative outcomes for our minorities or those who are uninsured. And then same-day discharge, I think, has a lot to do with those reduced costs by high-volume surgeons. And then just one word on adrenal. I don't know that much about adrenal disparities, and there really isn't that much written either. In this study of, again, an inpatient sample, everyone who got adrenalectomies, minorities were more likely to have them done by low volume surgeons, and high volume surgeons tended to have shorter length of stay and fewer complications. And then very similar for metastatectomy. Minorities were less likely to be referred for metastatectomy, even though they had similar comorbidities, and those with public insurance as well. But everyone ended up having similar outcomes. So that's a disparity in access. And that's all I have. I'm eager to take any questions and hear from you guys.
Oh, fantastic. Thank you so much, Andrea. That was awesome. Really good survey.
A whirlwind.
I'm gonna no, it's fantastic. It's just covered it all. I'm going to turn it over to Tony and then leave time for some questions at the end. So for those of you, can maybe enter questions in the chat if you'd like, or just save them up and we can talk about them at the end. But I want to leave a little bit of time for Tony Bagani to speak his mind and share with us some of his perspectives in his role as a member of our AAS DEI committee. Tony.
All right. Well, thanks, Wynn. And so I'm going to share the screen. We're going to see what's going to happen. Yeah, that's probably not helpful. So how do you make this go?
So you got the share screen thing in the middle, bottom middle. You got that. Yep. So hit that, and it should give you some options for different things. Let's see.
Desktop 1.
Yeah, I mean, whatever if your slides are, have your slides pulled up already? You have them already on your
Yep.
screen.
Yes,
so you need to select.
It's asking for some security things.
There's Navy stuff that. See what you got. And if worse, you can also just start talking, then maybe email it, and then email it to me, and then I can share it.
Okay, let me do that.
Thanks, Emily. No, it should be okay.
Okay.
Yep. So send it over, and then
Just sent it.
Yeah, and you can get started talking, and then I'll pull it up and catch up with you.
How was that? Do you guys see that?
Oh, you're good. So just go
Okay.
to yeah, slideshow at the bottom. There you go.
Okay.
Lovely.
Magic. Okay. Well, thanks everyone. And thank you for being patient. This afternoon, we'll be talking about diversity, equity, and inclusion, its importances, challenges, and recommendations for endocrine surgery. What's really nice is I think there's going to be a lot of overlap with what Andrea was talking about. And what I found was interesting is this has been talked about or discussed not only within surgery, but almost all industries, organizations, professions for quite a while. But what I thought was interesting is what causes new interest over the past 5 years. And there were a number of reasons, but I think the primary reason was George Floyd's death that we witnessed in 2020, where everyone saw that and pretty much it galvanized the world into thinking we can probably do better, not just in policing, but in how we interact with people within our organizations and greater society. And what we saw is a number of companies scrambling to voice support for Black Lives Matter or creating new positions or officers and increasing their commitment to that. And I think we did the same thing within our organization. But also, I think we have a history of the awareness of disparities in healthcare outcomes. And so those things, two things paired together, I think is what drove this increased interest in what we're doing. What's interesting is this, like I said, it's not new. The ACGME, which pretty intimately involved with, has had a commitment that goes back for a while. In 2013, they changed their mission to emphasize population health in GMA, specifically the role in addressing diversity in healthcare outcomes, or diversity in healthcare and improved disparities in outcomes. This continued in 2018, where the GME formed a specific committee to address diversity. It met 4 times over 2018, and they developed 3 working groups, one to look at physician pipeline and admissions, retention and well-being, and the ACGME is a conveyor of the community's collective efforts in encouraging population health factors improvements, including a broader awareness of social outcomes and race, gender, and the like. In 2019, they actually appointed their first chief diversity inclusion officer, Dr. McDade, and the focus was national initiatives to diversify underrepresented groups throughout the medical education community, with the goal of providing physicians with the knowledge and skills to serve the broader public. And this led to the mission of the ACGME and DEI to basically improve healthcare outcomes, addressing medical education, focusing primarily on racial and ethnic underrepresented groups, and providing a workforce that's consistent with the accomplishments of the above. And this is kind of what our initial focus has been, is how do we develop our workforce or endocrine surgeons that better represent the populations that we serve. And so one of the reasons, or one of the conversations that we're having that not everyone really thinks about, that we want to have a diverse workforce, but I think this goes to what Andrea was talking about, is the reason why. And part of it is because perceived and real disparities in outcomes, and basically, how do we make physicians and clinicians interested in those things? And part of that was seen, hold on one second, was seen in some studies that have been done, and one was looking at the impact of a diverse student body in med school and how it impacts students' perceptions of addressing underserved communities. And what the study was looking at, it was a study that was done. Med students were graduating across the country. There were 20,000 students that were included in the survey, and they were looking at med schools that have a population that were highly diverse versus those that were less diverse by ethnicity. And it found that where white students that attended were in the top quartile for diverse student bodies were more likely to self-identify as having interest in outcomes secondary to ethnic changes, interested in serving in those areas, and interested in doing research to better understand it, versus those who did not, which suggested that a diverse population in itself influences people's perception on how they want to practice medicine. And then Marcella did a study in 2019, which looked at, basically it was a study done in Oakland, California, looking at Black patients and how they interact with Black physicians, and does it change preventative measures that are taken. They paired Black subjects with either Black physicians or white physicians, and then offered them preventative services like diabetes tracking, flu vaccinations, cholesterol screening. And what they found is that the Black subjects were much more likely to talk with Black doctors about their health problems, that the Black subjects perceived Black doctors spending more time with them. Black doctors were more likely to write prescriptions. And what they found was the Black subjects assigned to Black doctors were 18% more likely to follow and receive the preventative measures as compared to the white physicians. Using a statistical model, they found that by doing that, it would have a decreased risk for cardiovascular related deaths, increased rates of diabetes, cholesterol screening, and the increased rate of flu vaccinations would lead to an estimated 10% decrease in flu-related deaths. So the question initially was, in a number of these, does a workforce that resembles the population improve healthcare? And what it found from a number of studies that minority medical students reported greater desire to practice in minority and underserved communities. They tend to practice and minority physicians tend to practice in minority or underserved communities. Minority patients tend to prefer concordant physicians in the sense that they tend to trust and respect them simply because of, I guess, the history of, to a large degree, of healthcare in the United States. There's an intention or greater intention to adhere to recommendations. There appears to be greater patient satisfaction and, to a degree, improved clinical outcomes. And minority medical scholars tend to study problems that impact minority communities or minority patients. And like I said, this kind of looks at, to a degree, what Andrea was talking about with, we see these outcomes, we're not sure what these outcomes mean, but we're not doing a great job of measuring things by ethnicity as we could during trials, clinical trials or studies. So we're extrapolating to populations that we really haven't studied. And then another study, which was done by Sauer from otolaryngology, which I thought is more applicable to what we're talking about, is they were finding that there was worse outcomes in patients, head and neck cancers in patients who were in underrepresented groups. And so they asked the question, we're seeing this, what does it mean? Why does it mean this? They don't have an answer. And so they did a systemic review of 155 studies from 2010 to 2020, and they found that only 57% of the studies reported race or ethnicity at all in any of the studies. So when you're looking at, say, for some of them with head and neck cancers of squamous cell or that nature, when we're talking about radiation or chemotherapy, we have no idea what really is going to work in these populations. We're not sure, how are they referred? What's the referral pattern? Are they delayed presentation? And just by not asking questions, we're unable to generate answers to these questions. And that, again, in my opinion, is one of the importance of having a commitment to diversity, equity, and inclusion within our profession, is that we might start asking these questions to a greater degree. And then Debbie Chin, I think this is one that was referenced earlier by Andrea, and we're not going to belabor the issue, is basically this review paper looked at a number of studies that demonstrated racial and ethnic minority differences in thyroid cancer referrals, diagnosis, and outcomes. What does that mean? Not really sure, because I don't think we're digging deep enough. And so the challenges that we face, and this is the same type of challenges that all organizations face, is I think people want to do something, but the question is what? And often with a lot of the organizations, there's a knee-jerk reaction to hire somebody or sponsor an event or form a committee. More often than not, organizations don't conduct a full internal review of what they're doing, where they are, what's their current position. they don't really understand the degree and effort and financial commitment to make a sustainable change. Including, even though, let's say, a number of organizations might say, we're going to hire a diversity officer. If that department or if that person is not housed within the organizational structure or the command structure and provided the resources and authority to affect change, it's just another committee that's used to, let's say, discuss Black Awareness Month in February. And it really doesn't change the organization. Another problem that organizations often face is they implement a change, but they don't step back, analyze the impacts, and make adjustments and improvements. And then the final thing is, we're thinking, is this going to be a sustainable change? And so that's, I think, the challenges that all organizations, including ours, face. And so for us, we need to identify what our biggest or our largest challenges is as far as endocrine surgery. And there's primarily two, and they were already identified by the ACGME. Pretty much, we have a finite pool of applicants. We have an ACGME pipeline. That's the pool that we draw from. We can't draw outside of that, and that's a rate limiting factor of what we can do. And the second is inadequate data collection of where we are and what needs to be done. Basically, for those that don't know, the physician pipeline is just a metaphor that the ACGME uses to kind of track who's going through the process of the graduate medical education to become fully qualified physicians or board certified physicians. That's what it is. So I'm going to go through a number of slides quickly so you can get a picture of what's going on. The first slide is looking at from 2011 academic year to 2020, and the total number of active residents that were in the ACGME pipeline during that period, or those periods. And then the number to the right, the much, much smaller number, are those that are in general surgery, not orthopedics, not cardiothoracic, not straight plastics, just general surgery. So that's the pool of our pipeline pool to come into endocrine surgery. And we're in competition with those that eventually may go into plastics or vascular or colorectal or bariatrics. And that's what we have to draw from. This slide basically is looking at that breakdown of residents by ethnicity. And Andrea was talking about, self-identification versus how we might identify people. And so these years, this was pretty much the standard categorization. White, non-Hispanic, Asian, Native Hawaiian, Pacific Islander, and the like. 2020 to 2021 academic year, they changed it and made it more stratified, which kind of, well, you'll notice they're going to change the unknown number and kind of redistribute it. But the trends are pretty much the same, is that the numbers of available candidates has pretty much stayed the same over a decade. That's our pipeline. This is when they changed the categorization of definitions, but as you see, not a significant change in what's available. And this is general surgery residents by ethnicity. So one of the biggest problems or challenges we face is how to draw more ethnically diverse groups from the current pipeline. The second challenge is retention within the pipeline. That not everyone that starts the program, the training program, is going to graduate from the training program. And again, this numbers have been pretty consistent over time of the percentage that leave the training program. What's more interesting, though, is when we look at dismissed by specialty in surgery, Black non-Hispanic is much, much higher than white non-Hispanic. In fact, everything is much, much higher than white non-Hispanic. So identifying those two areas, the finite pipeline and a retention problem, we know that those are the two areas that we should probably focus on if our goal is to increase diversity within endocrine surgery. And so in regards to the factors that influence retention, there's been a number of studies over the years that have looked at this, and they seem to be pretty common. Again, not just in surgical training programs, but in corporate America or other organizations. Bias and microaggressions that participants or these individuals have to basically contend with that, in addition to just becoming a general surgeon. Discrimination, actual and perceived. There is some actual, but there's also some people coming to the environment that perceive things going on or interpret things going on that may or may not be the case, but also may lead them to leave the profession. Differing expectations, whether it's this for ethnic minorities, or let's say in programs that are traditionally male dominated, and what expectations they have for women residents versus male residents. Different consequences for similar transgressions. Minorities are often tasked with being the spokesperson for that ethnic group, which is a stressor that majority trainees typically don't have to deal with. Social isolation, and then, you know, having to have an identity within the organization that they don't have to have outside. So again, the main challenge that we face is there aren't enough underrepresented minorities that reach incomplete training in the GME, and that is our source of workforce. That is our workforce. So the question is what to do about it. And there's a number of strategies that we can do to address that. One is systematic and directed recruitment. Given that we know our pipeline, we have to look at it from another way, looking at it as a multi-level, meaning we should probably conduct outreach at the med student level and at the undergraduate level, and basically have outreach going to the campuses and saying, this is what endocrine surgery is about. Actually try to recruit individuals prior to them starting residency to give them an idea, maybe I should look into this. There's been some programs that have actually started internship programs with undergraduates and med students, bringing them in for a week or 2 weeks to say, why don't you experience this? This might be something you might be interested in. And those are probably our two best approaches to addressing that. The ACGME has had other conversations about a more holistic approach to admissions in regards to how much weight USMLE scores should have. Because again, they're very, very similar to ACT and SAT scores. They measure how well one's going to perform on future tests, but there's very little correlation with how one's going to perform in the clinical setting. And so it's similar to how some universities have dropped ACTs and SATs because we're not measuring what we want to measure. They measure something entirely different, which is pretty much parents' income. That's pretty much what it measures. And then systemic retention. And what this is about is creating an inclusive learning environment. This is addressing those reasons why residents may drop out of a program, and basically creating an environment where students or residents feel heard and seen for individuals, for who they are. And basically trying to help them flourish in the environment and grow. Since we already invested time and money and energy in them, we want to keep them here. And then the third part is to objectively measure our outcomes so we can provide a sustainable level of activity. And this is where we get into moving from performative to sustainable. As we talked about, there's a number of organizations that I think began with DE&I initiatives. And I think that's part of the problem. It's seen as an initiative versus part of the framework of the organization. You know, in healthcare, we look at it as addressing health inequities and outcomes. If you're in business, you're saying how to increase your market share or your revenue or product design. But it should be integral to the organization, written within the organization's DEI, which is what we do. Look at it as a continual journey versus something that can be achieved and done away with. As we tried to do at the beginning, define how we benefit from our involvement with DEI activities. The goal is to improve healthcare outcomes. That each organization takes an honest look at themselves to figure where they need to work, because everyone, it may not be the same thing for every organization. And then solicit information for everyone, not just the people at the top, but throughout the organization, saying, what do you think we need? What do you think we could do better? And then constant assessment and adjustment. And finally, the things we talked about earlier that every organization should think about is outreach. This is in regards to us from our own local groups, whatever, you know, wherever we're working, is to figure out how we can get not only the people within the pipeline to consider us, but consider addressing them or approaching them prior to entering the pipeline. And that's also the resource that we're talking about. That's going to be an investment in recruitment, growth, and retention. Again, it's going to cost money. Mentoring. So within the pipeline, to decrease the probability of them withdrawing, how to mentor these students so that they will continue forward. Change the approach from a presence. We just need people with different faces at the table to actually include them in the discussions. And then it's, like I said, intentional shaping of the learning environment, and perhaps even including DEI activity in performance reviews of workers. And this is, yeah, that's pretty much, like I said, with the recommendations that it seemed to be in the literature that would be, gives us the most bang for our buck. Any questions?
All right, thank you so much, Tony and Andrea. Yeah, let's open it up. There was a question in the chat. I can communicate to you from Sam Zuber, saying it's a great session. With regards to minority physicians practicing in minority and underserved communities, does this also go for those who go into competitive, high-paying specialties? So I guess it's the specialists in these kinds of communities, I think is what the question is asking. Or Sam, do you want to clarify perhaps a little bit?
Yeah, no, that was kind of what I'm curious about is in particularly those really the high paying specialties. Are those individuals going back to those communities, or are they staying in areas where there might be more affluent or an ability to make a higher income?
Okay, I didn't drill down that deep on that. What I did see are those that go into, when you're saying the high paying specialties, I'm assuming you mean the more technical specialties that.
Yeah.
Okay. People tend to go in, as far as locations concerned, tend to go to those facilities that have resources to support them. That seems to be more the driver, that if I'm doing something that requires a lot of robotics, they tend to go someplace that requires robotics or that has those resources allocated in that direction. And so I think the choice is made by what resources are available versus where they want to practice often.
Thank you, Tony. Other questions from the fellows? You can put it in the chat or you can raise a hand. I guess, actually, Tony, if you can stop your share, then we can get the full,
Oh, thanks.
There's a lot of material, Andrea, that I think is going to be fodder for many research projects to come. Has there been a thought either from the research committee or from the DEI committee and the AES to like kind of put a little bit of like a call for research proposals in this particular area, or these are the under studied areas like you said adrenal or benign thyroid or whatever? Has there been an idea to put that out for it would be serve our junior faculty and our fellows and residents really well?
Yeah, I know there was a push to have a disparity session, poster session at this year's AES. But I think it's a great idea, taking it even back a step further. Like we need a lot more energy and investment into some of these problems and disparities that we're seeing. And, who will take the charge? I think that would be a great idea.
Yeah, but if you highlight the areas of need, I think that would be a great opportunity for those who are interested in starting.
Yeah. And I think a lot of the smart way to go about doing it is using those frameworks that are already set out by the NIH, the NIMD, and, everyone wants to fund it if you have a nice framework or a nice chart that lays out exactly how this plays into so many other things.
Cool. Other questions or comments from the gang?
I think just to
sorry, Wen? Hi. Oh, no, go ahead. Sorry.
Alan, let Adriana talk. Supersonic lurker. You graduated ESU many years ago. Adriana.
Sorry, I was actually just going to piggyback off of that and say that there is a health equity session, inaugural session this year, which we're very excited about on the DEI committee. And I will be presenting as one of the 5, so you guys should come.
Excellent. Good job, Adriana. Dr. Sipperstein, would you care to make your comment?
I'm not a fellow, but I want to make a comment anyway. No, I did. This is, as you know, a particular area of interest to me, and really appreciate the session. Yes, I just want to echo that for the first time we are having a specific session, and there's going to be $1,000 cash prize for the winner of that session. There were a record number of presentations, and a huge number are also being presented as posters. So hopefully this will be a breeding ground for new ideas and discussion in this area. I just want to, thank our DI committee for their incredible, work and effort in this area. And I saw Tony chatted me, and he's been a real, mover and shaker, in this area from day one. And just to educate the fellows just for a second, in that we have a relatively new DEI committee, through the AES, and the charge to that group was to really inform the leadership of what they felt the needs were within the organization. And unlike other committees that reported to another member of the council, the DEI committee reports directly to the president and secretary of the organization. So the purpose of that is to keep these activities top of mind. And also, I think a point that you made very nicely, Tony, as opposed to just something that is lip service, there are DI members that are now participating in almost all of the committees. So to provide that kind of close contact and close loop, so that the committee's activities have DEI representation. So thank you for all of that. And so, of course, since Tony's on, I get to ask him a hard question, because I always ask him hard questions. So I think the real question, Tony, is as an organization, how have we been doing, and what is your recommendation for how we can do better? Easy question, right?
Yeah, that's a great question. I do appreciate it. I did say it was good to see you. No, I don't say that anymore.
Good.
No, I think what we do quite well is, I think as an organization, is that we do have a sincere interest in the topic, and we are taking sincere measures to do it. And as you stated, trying to integrate it into the structures and the decision-making of the organization to make it part of the fabric of the organization. I think we're doing that quite well. I think the areas that we had challenges, and we discussed this the first year of our committee, is we really didn't know where we stood. We didn't have that information of, what are our demographics, who is applying, how can we better understand our state while not giving the appearance that, let's say, applying fellows, let's say fellows that are applying, without giving the appearance that we're making decisions on applications based upon race. I mean, it's really hard to do that. I think where we could do better is what we were discussing earlier, is reaching outside the pipeline to students that might consider us, the pre-medical students in undergrad and the medical students, to do that. I think we could do that a little bit better. The mentoring, I think that's someplace that we could do better also. Not so much in the fellows, because I think at that area we do quite a great job, but in the areas of where we're teaching at the general surgery level, our general surgery colleagues that we're teaching, that we could do a better job there. So yeah, I think the areas where we can improve our outreach, mentoring, the places we're doing well, is our sincere commitment to building this into our organization. Yeah.
Great, thank you.
Yeah.
Excellent.
Outstanding.
Other thoughts or questions from the game? We're a little bit over, but certainly worthwhile. Megan.
Hey, yeah, I guess I had a question, more for Andrea. Your presentation was great. It was very, very interesting. But we hear a lot of these presentations about these disparities in healthcare that exists, and there's problems with less referral and, different outcomes. But I was just wondering if you know of any actionable things that are being done to actually try and change it. Like, there's a lot of research going into finding these disparities and things that are really important. But I was wondering if there's anything being actually done and initiated and started either within AES or otherwise to actually make some changes and act on these disparities that have been found.
Yeah, great question. You hit on my pet peeve, researching and talking about disparities with any actual solutions.
I tried to find evidence-based interventions. I couldn't find any. That's why I just put, like my interpretations at the end there. I think one of the things that AAS is doing and does very well is promoting endocrine surgeons, and especially young endocrine surgeons. There's tons of like templated presentations and PowerPoints for recent fellows and graduates to promote themselves. I think that is a key way to reduce some of the inequities, is like making sure all patients have access to a high volume surgeon. We're never gonna make that 100%, but getting more and more patients in front of endocrine surgeons and high volume surgeons, as we've shown, improves complications and improves inequities and disparities. So there's, multiple benefits to that. The other is, being advocates for patients, going out into the communities. I think accepting self-referrals, making sure endocrinologists don't find it a huge barrier to send their patients. Even in the high volume centers, in our study, we showed we were only offering 20% of hyperthyroid patients referral to surgery. So like we are failing, even though we are high volume surgeons. Now that study is like 5 years old. So hopefully if we redo it, it's better now, because we have been doing a lot of that work.
Awesome, thanks.
Thank you.
Excellent. Well, certainly I want to thank you both, Andrea and Tony. Real quick for the rest of the fellows, I won't make it too long. We'll be seeing each other in about a month at ESU. There's no preparation, to like study or anything, although there is a Jeopardy session at the end. But certainly come prepared to engage and be involved, right? I mean, there are panel sessions, great faculty, cases will be presented. There will be discussion amongst the panels, but I have very specifically instructed that they will involve you all and ask, what do you think? What have you learned? What do you plan to do? And to really kind of contextualize the things they're presenting to like really be pertinent to what you will be facing in your first year or years in practice. So be ready to engage and to be involved, and come with like energy and enthusiasm to like meet and network and integrate with our faculty and everyone else who's going to be participating in ESU. It's great opportunities to pick their brains, to really ask. They're there for you. So definitely we want to make sure that during coffee breaks, during our cocktail reception and the fireside chat dinner, all those kinds of things, that you take advantage of all the different people that are going to be available to you. Because certainly we don't take it for granted after the couple of years we missed during the pandemic, and we want to make sure that it's as useful and worthwhile and memorable for you as possible. Hit me up with any questions or thoughts you have before ESU. Otherwise, I think you should have all your info and have made your travel arrangements and all those kinds of things. And we'll have a great time in Dr. Gillis's new hometown, Birmingham, Alabama. So all of you take care, and see you in about a month. Thanks so much, Tony and Andrea.
Thank you.
Thank you.
Thanks.